Good morning, everybody. It's loud enough. I'm glad I waking you up. First of all, thank you very much for coming so early morning, and I'm sure you will have a great day today because we have a great start with Dr. Nanette Wenger. By the way, this is a CME accredited program, so the mid-intelligence group, so that make sure you will also have that at the 11.5 hour you have professional meetings. And of course, the speaker needs no more introduction. However, some of you maybe will not hear Professor Nanette Wenger, basically who is not only in the national cardio, in the international scene. She is a professor at the Emory University School of Medicine, and she is the most expert who trained most of the cardiologists around the country. She is the mother of all of us. Give her a warm applause, please.
You should be good to go.
Good morning. Good morning to all of you early birds. And I am the worm that you have caught this morning. And what we will do is talk about something that is an area that I usually don't address, but something that has excited me since I heard this information just a few months ago at the American Heart Association scientific sessions. You know, years ago, we would talk about cholesterol and talk about triglycerides. And with so many negative triglyceride trials, somehow triglycerides fell off the radar for many of us, except when it's terribly high and you worry about the risk of pancreatitis. But I don't think that's appropriate. And the trial that was completed that I will start off with, I think has changed the landscape. And as background for this, obviously with my interest in women and heart disease, you know, all the epidemiologic studies say that triglycerides, the high triglycerides and the low HDL, are far, far more virulent for women than they are for men. And that was another reason that this interested me, although in most of these studies, there were not substantial gender differences. So what we're going to talk about is elevated triglyceride levels and cardiovascular risk. And the question is, with the new information, what are the implications for management? This is too new. It's not gotten into the guidelines. But we don't have to wait for guidelines. We can start with best information. I have no disclosures for this. And this is the Reduce It trial. Reduction of cardiovascular events with isopentoethyl intervention trial. And I'm summarizing it for you now. We will go back to details a little bit later. But compared with placebo, EPA at a dose of 4 grams daily significantly reduced important cardiovascular events by 25%. And that included a 20% reduction in death, a 31% reduction in MI, 28% reduction in stroke. And in this spectrum, a very low rate of adverse events. One which we don't understand, a small but significant increase in atrial fibrillation, and a non-statistically significant increase in serious bleeding. So it's there, but it doesn't reach the point of statistically significant. But if it's there, I always mention it. But the most impressive is that this was a consistent efficacy across all the subgroups, as I will show you, including a baseline triglyceride from 135 up to 499. 499 is the safest we'll tolerate because at 500, all of us would treat rather than randomize. And this study had both primary and secondary prevention cohorts. This shows the same thing in a beautiful and clean graph showing the percent of patients who had any event over the 5 years since randomization. And if you look at the p-value there, it's just overloaded with zeros. Very, very impressive. relative risk reduction, as I said, of 24%, but an absolute risk reduction of almost 5%. And then there were a number of key secondary endpoints: cardiovascular death, MI, and stroke. Again, a very impressive relative risk reduction of 26%, absolute risk reduction of almost 4%. So with that as background, let me let you go over the design of the trial so that you see who's there and you see if these people mimic the patient who will be sitting across the desk in the office. Men and women over age 45, either with established coronary disease or at high risk, and the high risk were diabetics who had an additional risk factor. And they all had to have an atherogenic dyslipidemia. They had to be on a stable statin therapy for 4 weeks, and statin remained stable throughout the course of the study. The LDL was between 40 and 100, so not very, very, very low, nor was it very, very high. That's acceptable range just before randomization. And their fasting triglycerides had to be between 135 and 499. And this is the classic RCT, randomized double-blind parallel group. And the secondary outcome measures that I listed for you were pre-specified: additional cardiovascular events, lipid levels, lipoprotein levels, and then analysis of relative subgroups. And obviously today we're focusing very much in on the diabetic groups. And the primary endpoint, as you can see, is the first major cardiovascular event, which could be either death, non-fatal MI, non-fatal stroke, coronary revascularization, or unstable angina severe enough as to require a hospitalization. The standard blinded clinical endpoints committee, but I think when you say who are these people, about 10% had really low triglycerides, 135 to 150. So again, let's see what happens with them. 2 cohorts, secondary prevention cohort and primary prevention cohort. The second, again, over 45 years of age, established disease. The primary cohort was older, over 50 years, with diabetes and at least an additional risk factor. So that was a high-risk primary cohort. I've told you the fasting triglyceride levels. And you're going to say to me, if you're awake, you just said 135, and here you have 150. At the beginning, they enrolled closer to 135. Later on, tried to keep it to 150, but for honesty's sake, there are 135s in there. And the LDL between 40 and 100 on stable statin therapy. Now, in order to get into the secondary prevention cohort, they had to have documented coronary disease. That's at least a 50% stenosis in 2 arteries, with or without revascularization, prior MI, hospitalization for a high-risk non-STEMI. So the very small non-STEMIs didn't get into there. They had to have either ST segment change or biomarker positivity. They had documented cerebrovascular carotid disease, stroke, carotid artery disease, or carotid revascularization. And as we heard last night, disease affects all 3 beds, and you have to consider them. And those were considered in the enrollment for this trial. Documented peripheral artery disease with an ABI of 0.9 with symptoms of claudication, and an intervention for aortoiliac or peripheral artery disease. So there could be coronary disease, there could be cerebrovascular carotid disease, there could be peripheral artery disease, or any combinations. So these were not barely ill patients. This was a good secondary prevention cohort. In the primary prevention cohort, the main criteria was diabetes requiring medication and over age 50 and 1 additional risk factor. The men had to be over 55, the women over 65. There had to be at least recent cigarette smoking. That was that could be 1 additional risk factor. Hypertension was 1, and HDL below where we wanted, HSCRP higher, renal dysfunction, retinopathy, micro or macroalbuminuria, and an ABI, even without symptoms, could be the additional risk factor. So again, these are diabetics, not young, with at least one risk factor. And who didn't come in? Class 4 heart failure, severe liver disease, history of pancreatitis, obviously worried about the high triglyceride, and hypersensitivity to fish or shellfish. So this is a very inclusive group. Now, I'm not going to go over all of the baseline characteristics. They were very well matched, but the mean age was 64. A little more than a fourth were women. The predominant groups, about 71%, was non-white because they came from the westernized regions, many of them from Europe. About skimpy 10% non-white. 2/3 secondary prevention cohort, 1/3 primary prevention cohort. Small number using ezetimibe, and most of them on moderate or high dose statins. Half of them were diabetics. Obviously, all the secondary prevention had some diabetes, but the primary prevention cohort was loaded with the diabetic patients. LDL median for the group was 76. Very busy slide. Just look at the part that is bordered in red. And you say after 1 year, randomized to placebo or EPA, there was a 19% decrease in triglycerides, 13% decrease in non-HDL, 6% decrease in LDL, 6% decrease in HDL, 9% decrease in ApoB, major decrease, 39% in hsCRP. So a major lessening of the inflammatory component. And the same thing looking at the log of hsCRP. And obviously you see the high level of EPA that was measured. Now, what about the tertiary endpoints? And remember, these are all pre-specified. And when we look at placebo and we look at EPA, and let's look first above the line and over here, above the line at the revascularization endpoint. Pretty uniform, about 0.6. So almost a 40% lessening in the totality of revascularizations. Granted, that is somewhat elective, but not always. A lessening by half in cardiac arrest, and a lessening by about a little over a third in sudden cardiac death. So we're seeing benefits across a huge spectrum. And I think this is what has pleased most of us, because it's not targeting, it's not just there's benefit for fatal MI, or just there's benefit for non-fatal, or just for stroke. Here we're seeing just a broad brush of benefits. Adverse events, very important, and two of them are the serious bleeding and the AFib. The bleeding-related disorders, none of them reach statistical significance. But when I see a 0.06, I'll say it's there. And most of it was GI bleeding, very little CNS bleeding, very little other bleeding. So there is bleeding, but it's not much. And the predominance seems to be a gastrointestinal bleeding. And the one thing that, again, we noted, and I think is probably going to show up in our clinical practice, is atrial fibrillation or atrial flutter. And why it is more prominent in the EPA group than in the placebo group, I'm not sure. We don't have things like echo, atrial size, etc. But there are EKGs, and I think someone is going to go back and look and see if there's difference in atrial enlargement on the ECG. But no good explanation for this. Highly significant. And then these are the other events, and that is part of the requirement for FDA reporting.
And they differ between the two groups. More diarrhea in the placebo group, more peripheral edema and constipation in the EPA group, more atrial fib in the EPA group, and more anemia in the placebo group. And while statistically significant, these are relatively low percentages. And the only one that gives me cause for concern, as I've said, is the atrial fibrillation. So much so that if I were to start a patient, this is one of the things that I would mention to the patient in the discussion. Now, you see why I love the study, but it does have limitations. There weren't that many patients on ezetimibe, although their results weren't different. Remember, the ezetimibe will lower LDL by about 15%. In this study, they did not allow PCSK9 inhibitors, but they should be additive, but that's pure guessing. There was a very small difference in LDL between the groups, and you can't tell if it's due to the study drug or due to placebo. But that small difference in LDL does not account for a 25% relative risk reduction. That's important. I'm going to tell you in a moment about the Japanese JELIS trial. That was an open label design, and they saw a 19% relative risk reduction. But what we've learned is that for so many reasons, we can't truly translate back and forth between Western populations and Japanese populations. But important, there was a consistent benefit both in those patients where the LDL was high and where the LDL was low. So LDL didn't seem to have an impact on efficacy. Mechanism is uncertain. There's consistent reduction across the whole triglyceride range from 135 to 500, and even similar benefit at 1 year when the triglycerides were roughly where we wanted, above or below 150. Cost effectiveness, we don't know because the drug really hasn't been priced out yet. But with a number needed to treat of 21, it's highly likely that when all the numbers are in, it's going to be a cost-effective intervention. Now, let's go back after I have given you the trial data in, I think, appropriate detail for you to have some idea of it, and talk about the prevalence of elevated triglyceride in the US. Overall, it's about 31% have a triglyceride over 150, fewer over 200. Men have a little higher triglyceride in both groups than women, but still the percentages are in a reasonable range. But the ethnicity tends to be really important. The non-Hispanic Blacks have less of an elevated triglyceride, and it is about equally high in the Mexican American and in the non-Hispanic whites. So our Black patients have less of an elevated triglyceride. And then we have the classification, and probably this classification from the National Lipid Association is the one that most of us use. An optimal triglyceride is below 100, a normal is below 150. Borderline high, 150 to 199, high, 200 to 499, and over 500, very high. And over 500, you will get a red flag on your reports because that is where you have the high risk of acute pancreatitis, which is probably one of the most serious complications of high triglycerides. Now, why does an elevated triglyceride or triglyceride remnants drive cardiovascular risk? What is there about it that imparts risk? 2 lipid-based and 1 non-lipid-based, theoretic, but reasonable. What you see is that when there is an elevated triglyceride, there is an increase in the small, dense LPL. You see the CETP effect, and you see the small, dense LDL, and the small, dense LDL is the one that goes into the vascular wall as macrophage. Then the other, and because of the major change in CRP, I keep looking back at this again and again because CRP tells us about inflammation. And the triglyceride-rich lipoproteins give rise to inflammation and accentuate atherogenesis. So what we see is, again, putative transducers and transcriptional activates. They recruit leukocytes. Inflammation is MCP1, IL-8, and others, and all of these adversely affect the endothelial cell with an increase in vascular cell adhesion molecules. So these are the standard detriments when you have an inflammatory state. And high lipoproteins seems to encourage this inflammatory state. And you saw the change on the therapy group of the drop in HSCRP. And then this enormously complicated slide talking about non-lipid factors that drive cardiovascular risk. Because those first two really are lipid issues. But here, probably the highlight of them is in the red box at the top. Coagulation factors, impairment of fibrinolysis, pro-inflammatory factors, and endothelial dysfunction. And this is the perfect storm for atherosclerosis. Now, anytime you see a patient who has hypertriglyceridemia, the first thing you have to do is to say, is there a secondary cause? And the secondary causes are treatable and some curable. And of course, at the top, I'm putting caloric imbalance for the patient who doesn't exercise and who has an excess of saturated fat, a high glycemic index, and excess alcohol take. You see this with increase in carbohydrate intake, simple sugars, and again, fructose is the major villain, and a decrease in dietary fiber. You see this when there's adiposity, and in particular, visceral adiposity. Poorly controlled diabetes. You know when the diabetic patient comes to your office and suddenly they're out of control. They stop their medicine, they've altered their diet, have gained weight, triglycerides are going to be up. And that basically tells you you've got a new problem and we've got to get the diabetes under better control and the triglycerides down. Hypothyroidism, uncontrolled, obviously high triglycerides, and the nephrotic syndrome. There are a number of medications that are important, and what we've done is to put in yellow the common ones. The antiretrovirals that are used for HIV, oral estrogen, but not patch estrogen, glucocorticoids, and isotretinoin. Those are the common ones. Then there are a few others. And then the recreational drugs also. We've not made enough emphasis that many of the recreational drugs, alcohol, heavy marijuana use, will increase triglycerides. Now, what do we have available for FDA approval? The statins are approved for, and here we're talking about triglycerides over 100, where you're worried about the pancreatitis. Statins are approved, but we know what they have as major side effects. Omega-3 fatty acids are approved, but they have some arthralgias. The omega-3 fatty acids, both the EPA and the DHA, again, will give you some bad taste, some dyspepsia, etc. The ones that we had used for a while, we now have FDA warning and retractions. Fenofibrate, enough abnormal liver tests, myalgias, renal dysfunction, etc., that the FDA really has downgraded it in terms of usefulness. And I've basically stopped using fenofibrate. Extended release niacin, again, a new FDA retraction, flushing, nausea, diarrhea, vomiting, cough. I've always had problems getting patients to take niacin. And here, the adverse effects seem greater than the benefits. So we have the FDA warning on fenofibrate on extended release niacin. And I think some of this is why people's interest in triglycerides has waned. What about the studies? I'm not going to go into them in detail, but we have good RCTs that document what I've said to you. In Accord, using fenofibrate, even though the triglycerides decreased by 26%, there's no benefit. And in Field, using micronized fenofibrate, even though there was a 30% reduction in triglyceride at the end of the first year, again, a negative trial. And then what was done is to take both Accord and Accordion and combine them to look at the risk. And this is what really spooked the FDA. There was an increase in renal endpoints and an increase in all-cause mortality when fenofibrate was used in a group of diabetics. More macroalbuminuria, doubling of creatinine, need for dialysis, or death by any cause. So this is, in my book, a do not use. Aim High, again, starts looking now at niacin studies. And this is on baseline statin use. And if you see two lines superimposed on each other that are better superimposed than these, show them to me. There was just no effect. And HPS2 Thrive, again, on effect on major vascular events, no effect of niacin. This is a study that brought EPA back into the world. This is a Japanese study, again, potential limits in translation. But here you see the patients getting now, the dose now becomes important, 1.8 grams of EPA. And for the total population, for the primary prevention cohort, and for the secondary prevention cohort, there is a very prominent difference with a p-value of 0.1 for the total population and 0.4 for the control group. Not significant in the primary prevention cohort. But again, not very large numbers and a non-US cohort. Then the JELIS trial, again, saw a decrease in MACE in those who had the higher triglyceride, higher than 150, and a low HDL. And that group had a 53% decrease when it was adjusted for everything. So again, an impressive study which says we better look again at EPA. Now, what do we have as background? What do you expect to see when you see patients in the office? The estimated global market for omega-3 drugs a couple of years ago was $31 billion. Lots of patients are taking it. And a prospective study, not in the US, but in the UK, said that 1/3 of adults were taking some kind of fish oil. Now, this is all different preparations, all different doses. But this is a very, very high percentage, many of them over the counter. And about almost 8% in the US take some kind of fish oil supplement, some prescriptive and some not. And if you go through the literature, it does everything. It has benefit on the heart, brain, weight, vision, inflammation, skin, pregnancy, early life, fat, depression, child behavior. It reminds me of the benefits that were ascribed to estrogen before we did all of the estrogen trials. So none of these studies would pass muster. Many of them are observational. Many of them are short-term. Many of them are questionable for the data. But if you look at the Sunday supplement of any paper, you will find fish oil postulated to do some good thing for some people. But as we all know, we need the randomized trials. That's our evidence base. Now, this is probably the largest study done previously, and this is a trial primarily in the UK. Ascend. Patients had to have any diabetes, type 1 or type 2, older than 40, and no known cardiovascular disease. Big group, 15,000 patients. And they got omega-3 fatty acids, 1 gram a day compared with placebo, followed up for over 7 years, and almost complete follow-up, which is better than most of the trials that any of us see. And the average adherence was about 77%. And these are big capsules. Largest, longest placebo-controlled trial, and nothing happened. So people said, well, here's another one back. Excuse me. A well-done UK trial, the end of omega-3 again. And people get discouraged when they say, well, we now saw fibrates, we now saw niacin, now bad EPA. Is there any way, thank you, is there any way we can change this? Or is it that triglyceride lowering isn't important? And in Ascend, no serious vascular events, no effect on cancer, and no safety concerns. And then we had the vitamin D and omega-3 trial. And my conflict of interest is that I chaired the DSMB for the 8 years of that study, which means I know it very well. 25,000 participants. It was a primary prevention trial. Half of the participants were women. There was specific over-recruiting of women, and 20% African American. And there was specific over-recruiting of African Americans because skin color influences vitamin D absorption from the sun. Omega-3 was 1 gram a day. Vitamin D was 2,000 international units per day. Patients were followed for over 5 years. And the hazard ratio was 0.92 with a non-significant p-value. So no cardiovascular event, even though there were a sizable number of events, they were equal in both groups. And there was no lower incidence of major cardiovascular events or cancer. So both of the endpoints negative. And that was also reported out at the same meeting at American Heart last November. And at the same time, European Medicines Agency, which is the European FDA, basically said that omega-3 at a dose of 1 gram per day has no cardiovascular benefit. So here we see all of this and no cardiovascular benefit. It says if you look at the very last line, these medicines can still be used to reduce levels of certain types of blood fat called triglyceride, but we're not considering them a preventive medication. And then what is it that you can do if you have someone on a maximally tolerated statin for risk reduction? Well, you can add ezetimibe, and that will give you about another 15% reduction in LDL. Here we're talking about kisopentanoic acid and the PCSK9 inhibitors. We'll have another talk at this meeting on PCSK9, and I'm not going to address it, but very costly, very difficult to access injectable medication. Enormously effective in all the trials. So when we talk about personalized medicine, and what we're doing now for the guidelines is really not saying one size fits all. Let's consider the characteristics of the patient in our conversation. The biologic residual risk that you have, even with a high-intensity statin, can be still some cholesterol, inflammation, thrombotic, triglyceride, and LPA. And for cholesterol, where you're looking at both LDL and ApoB, it is basically the PCSK9 trials that we have that have shown benefit. And that's Improve It, Fourier, Spire, and Odyssey. And the PCSK9 drive down the LDL cholesterol levels very low. The inflammation trial, which was headed up by Paul Ritker, was the CANTOS trial. It showed some benefit The benefit was significant but small, and some side effects, and the company has chosen not to release that drug to market. I think they just did not see a sufficient market for it. Now, for thrombotic, there is no biomarker to measure for thrombotic risk because there's so many components. But COMPASS and DAPT were the ones that have addressed that. And now for triglyceride, we have REDUCE-IT, the one that I've detailed to you. There are 2 and possibly 3 Lp(a) trials that are in the planning stage. And that's something that I would not discount, but we have to see, will they get off the ground and what will they do? But REDUCE-IT really is the new kid on the block that has given us messages, and it's given us messages that are contradictory from the negative trials that I outlined for you. Now, here are the prevention guidelines, and they are complex. Let's look first at the primary prevention. And basically, below age 19, if it's not familial hyperlipidemia, it's lifestyle. And then you have something different in the very young adults, the 20 to 30, and the older individuals, 40 to 75. No recommendations over age 75. That does not mean that over age 75 they don't take medicines. It means they were not in the trials and we have no data. Very important. And in general, for the 20 to 39, consider statin if there's a family history or premature or something else. But once you get to 40, you're beginning to say that if the LDL is up, then you begin the risk discussion. Doesn't mean you have to use statins, but you tell patients there may be benefit. Here are the benefits, here are the risks. You make up your mind. And this is the shared decision making. I must tell you, I was at a staff meeting and discussing how you do it, the principles of shared decision making. And one of my surgical colleagues, who shall remain nameless, said to me, "That's exactly what I do. I make a decision and I share it with my patients." Now, that's not shared decision making. Okay, now this is what we do. LDL over 190, high intensity statin. Diabetes, moderate intensity statin. This is primary prevention. And diabetes, what you have to do is also get the risk profile because you may want to go to a high intensity statin. And over age 75, it's a discussion. But you know, I find this is almost a null set. There are so few patients over 75 where I start statin de novo, except in the setting maybe of an acute coronary syndrome. And there they need high intensity statin. So that's almost a null group in my practice. And then we're looking at the risk that we discussed all day yesterday. And basically, the higher the risk, the more powerful the argument for statin. Low risk is lifestyle. There are many factors when you get the moderate risk, family history, etc. And patients' level of worry and patients' willingness to take preventive drugs on modest evidence. And this to me is really, really important. There's a line here, and I think this is what I told my fellows, get this one on your phone. The ASCVD risk enhancers. Because if there's a family history of premature disease, if there's a persistently elevated LDL over 160, chronic kidney disease, metabolic syndrome, specific to women, preeclampsia, premature menopause, inflammatory diseases, ethnicity, persistently elevated triglycerides over 170, elevated CRP, elevated Lp(a), ApoB, abnormal ankle brachial index. These are the ones that can be at a tipping point from low risk to medium high to high. And if these are present, these are the ones that I go over with patients. And this is a list that you need because I find that particularly for women who are generally at lower risk, that if the inclusion of pregnancy complications, and we've talked about that at this meeting, is considered, they often become a higher risk category and they are candidates for intervention. And to complement Erin's wonderful talk yesterday, if the risk decision is uncertain, consider measuring coronary artery calcium. Because coronary calcium means atherosclerosis. And if there's atherosclerosis there, you're going to move a lot faster than if there is not. Now, the secondary prevention guideline, again, equally complicated, but once you go through it, it really makes sense. And if you do this and go through it gradually with the patients, the way I'm doing now, then they'll follow you and see why my friend down the block is taking a statin and I'm not. My friend down the block is taking a statin and a PCSK9, et cetera. Because a lot of this doesn't make sense. But with lipid lowering, we're beginning to realize one size does not fit all. Not at very high risk, you define those above and below age 75, again, because we have precious few data over age 75. And if they're not at very high risk, if you look at you want a statin that will get the LDL down by 50%, and that's a high intensity statin. If you're satisfied with an LDL reduction of 35, that's a moderate intensity statin. So that if they don't tolerate the high intensity, then you go to the moderate. And I find sometimes I can creep up. Age 75, you have to talk, you have to talk, you have to talk. And I usually tell, particularly the healthy patients, that they have a good number of years to live. And this statin is usually a pretty good drug to help that. Very high risk gets high intensity statin. If the LDL is not down by 50%, you add ezetimibe. The recommendation is try to add ezetimibe before you go for a PCSK9. That's one of the questions you will be asked when you call for permission. And again, I think adding PCSK9 is now a 2A. It's reasonable if the maximally tolerated other lipid lowering doesn't work. But now let's get back to triglycerides, because that's not in the guidelines yet. And the question you should be asking me is, in Reduce It, why did this EPA reduce cardiovascular events when the other omega-3s didn't? And that's the immediate question. Well, first place, this is the highest dose. It's 4 grams. The other next highest dose was 1.8. And it was pure EPA. It was not EPA-DHA combinations. And EPA alone has pleiotropic biologic effects beside triglyceride lowering. EPA will stabilize membranes. It will reduce the oxidation of LDL. It will improve endothelial function. It will reduce cholesterol crystallization. It seems to act in synergy with the statins. And I think one of the more important things is it reduces the cardiovascular-related inflammatory targets. Because I think that atherosclerosis is probably a combination of lipid, thrombosis, inflammation. And this one, EPA now, is getting 2 of those. I'm not going to go over this in much detail, but I think the colors say it all, that EPA and DHA have very different effects on the cellular membranes. And in Reduce It, we were using just a pure EPA and in a higher dose than in any other trial. So let's look at the lipid therapies that we use and see what it does to inflammation. And I'm using HSCRP as the inflammatory one. Statins decrease it. EPA, 4 grams, the Reduce It trial decreases. 4 grams of a statin, you get a double whammy with this. EPA and DHA, 4 grams, neutral effect on, and ezetimibe, neutral effect. ezetimibe and statin decreases it, but I think it's the statin effect because we saw ezetimibe alone did not. So very different inflammatory effects, even with comparable lowering of triglycerides or LDL cholesterol. And here in the REDUCE-IT trial, where HSCRP was measured, as you look at the boxes in the red, in the EPA group, the median change from baseline was 21, and that's a log change, and nothing in the placebo group. And therefore, I think that may be a very important component of the benefit that we see. Now, there are a lot of promising therapies for hypertriglyceridemia, now that our focus is back in on hypertriglyceridemia. They do impart residual risk even after you achieve an LDL goal. And sometimes the LDL goal is suboptimal, or you can't even achieve it with optimal medical therapy. And the triglyceride-rich remnant particles, small, very low density or intermediate density lipoprotein, are proatherogenic, pro-inflammatory, and prothrombotic. So what we are likely to see over the next year or two is at least the initiation of novel fibrates in trials. But remember, it will take us several years to achieve these data. Possibly omega-3s at a higher dose, and some of the omega-3s that may have pleiotropic effects. There are a number of early stage approaches that are now in pilot trials, antibody-based, antisense oligonucleotides, small interfering ribonucleic acid. So we're still going after the triglycerides, but with different types of medications. And I think we will see these out in the next 2 to 5 years. So what do I suggest that we all do in the office? First, diagnose and treat secondary causes of hypertriglyceridemia. When you see a high triglyceride, in addition to ensuring that it's a fasting specimen, take a history, calories, fat, sugar, alcohol, body weight, weight changes, physical activity, and ask the patients not what do you want to do for physical activity, but what did you actually do Monday, Wednesday, Friday of last week. Measure BMI, waist, check thyroid, fasting glucose, A1C, urinary protein. And the diet is a low calorie, low sugar, particularly low fructose, low to no alcohol, and low fat but high fiber diet. Patient appropriate physical activity plan. And then treat the underlying diseases, such as diabetes and hypothyroidism. So you address the secondary causes and possible changes from those triglyceride-raising medications that I gave to you. So try to get out of the equation the secondary causes of hypertriglyceridemia, because that will help you focus on treating. Now, how do you screen and manage elevated triglyceride? You can screen with a non-fasting, but if it's really bad, you're going to do the fasting anyway. So if you have a choice, do it. Under 200, just follow-up is required. Over 200 is where you get the fasting with the protein panel, and the recommendations, the dietary recommendations are there. Weight loss, decreased carbohydrates, aerobic activity at least twice a week. The question is, what do you do if the patient shows up non-fasting? You can do it, because if the values are normal, you're fine. If they are abnormal, you want to repeat the fasting. And if it's over 500, absolutely repeat a fasting. And then I think what you have to do is, once you start therapy, you need to follow that very, very carefully. You can assess non-HDL in the non-fasting state. But if I'm starting a patient on a new medication, as with EPA, I prefer, even though you may not need it, a fasting specimen, because I want everything fasting. I can't compare a non-fasting to a fasting one that I'm going to get later. But the important feature, and this is something that I would print out and give to patients, you can do a tremendous effect with diet and lifestyle. And most patients will say, can I do this first? So weight loss in overweight or obese individuals can drop the triglyceride by about 20%. A good diet, and this is essentially a Mediterranean diet, can drop the triglyceride by 10 to 20%. And exercise is variable, but there is some drop in triglycerides. It depends on how much exercise, it depends on where you start. So diet and exercise is where I start first. I never start a patient on therapy unless triglycerides are over 500. And that's really a pancreatitis worry. So you can get up to 50% reduction before you start the medication. And I think patients have some sort of an incentive because you say, if you can accomplish this with diet and exercise, this is a medication you don't have to take. But what is it that I do in the office? 2019, when I see a patient who has high triglycerides, first, rule out the secondary causes. Very, very important. Then I have a rather detailed discussion about lifestyle and dietary interventions and the fact that done well, 20, 30, even up to 50% lowering of triglyceride levels. And then the discussion about EPA. Remember, that has not yet been recommended either by the European Union or by the FDA. Brand new trial just came out in November. But my guess, knowing what these data look like, is that that's going to be in the guidelines the next time that they're there. And I thank you for your attention.